Evening, a very good evening. First of all, tell me whether I'm audible and visible so that we can start the session. A very happy evening, everyone. I hope and I believe all of you are doing well. So today's YouTube live session, it's an anatomy short sprint, and this is more like active recall of the important topics that we are going to do. Active recall for the students who have already watched the short videos on the MedSynapse app, and a quick learning for the students who are not there on the MedSynapse app. So this is absolutely useful for everyone. Right, so if you see FMG ke liye, definitely this session is definitely going to be very important for the FMG exam. We are going to have this for other subjects as well. So FMG, NEET PG, all the exams, please remember that whatever is important for FMG is definitely important for NEET PG. So like if this is the core for FMG and NEET PG, right, beyond that you will have something more for NEET PG also. So when I say it's for FMG, definitely it's for NEET PG as well. Right, this is very important, and you will definitely see questions from here in your upcoming exam, whether it's FMG or NEET PG. Okay, so I've already shared the blank PDF, right? If you want to make the notes as we discussed, I've shared the PDF on my Telegram group. So you can download the PDF from there, and as we discussed, you can make notes along with me. So how you should approach these sessions is attend the session live. In case you missed the live session, you can watch it as a recorded session, and then revise it immediately after the session is over, right? So what should be the sequence basically is watch the session live, make notes, then revise it immediately after the session, and then what you should do is give 1 day ka gap. Right, so for example, if we are doing the session now on 5th of June, give a gap of tomorrow, and then a day after tomorrow, that is 7th of June, solve the anatomy short shot based test, which is there on MedSynapse app by Dr. Nikita. And that test is going to be accessible only to the subscribers. So the MedSynapse app subscribers, please make the best use of those tests, right? So we'll be discussing the important points, the core important points. If this is your syllabus, short is this much, the sprint is even lesser than that, and based on this you have the short based test available in the app, so the subscribers can access that and assess themselves at how well you recall whatever you learn, right? So that's going to be a test of your recall power basically. Okay, is this clear with everyone? Yes, Neha, that is what the plan is, because we have the ongoing timetable, the daily targets that we have. Right now, we are on the third minor wale subjects, PSM, ENT, Opthal. So we are done with first year and second year subjects. So to keep revising the subjects which are already done, we shall be having these sessions as well. Okay? Okay, for those who have already solved the test, this session is a revision for you. See that if there is any area which you had still forgotten while doing the recall, highlight it in your notes or write it down somewhere. This is something I forget, and keep revising it again and again. Okay, so without any further delay, let's start. So we have divided the topics, the topics to be discussed section wise. So starting with upper and lower limbs, I would expect all of you to participate in this and answer this in the comments. So the first topic that we have, rotator cuff topic, right? So which is the muscle which is unique among the rotator cuff muscle in the way that it inserts onto the lesser tuberosity, not on the greater tuberosity. So rotator cuff mein basically you have 4 muscles which is sits. How do you write the T? Remember, it's a small t. To remember that, it is teres minor, which is included in the rotator cuff. So supraspinatus, infraspinatus, teres minor, and subscapularis. Out of that, which one inserts on the lesser tuberosity, guys? Very good, Harini. It is the subscapularis. Okay, what muscle inserts on the lesser tuberosity is the subscapularis. The last one, the first three, supraspinatus, infraspinatus, teres minor, they go on the greater tuberosity. Subscapularis, remember sub matlab less, that is lesser tuberosity. Going on to next one, which of these muscles are innervated by the suprascapular nerve? Out of these four rotator cuff muscles, which have the same innervation and they are innervated by the suprascapular nerve? Neha, it's not teres minor, it is subscapularis which goes on to the lesser tuberosity, right? This is how you realize कि ये मैंने पढ़ा है, test भी solve किया है, but still I'm making mistakes. So note it down कि ये मेरा गलत हुआ. Right, so remember that in the rotator cuff, it is teres minor. Okay, so Neha, you had answered for teres minor, I believe. अच्छा, अभी मुझे बताओ कि which muscles out of these four are innervated by the suprascapular nerve? Suprascapular. Subscapularis is subscapular, so that's not the answer. It is supraspinatus and infraspinatus. Supraspinatus and infraspinatus. Going to the next one, which muscle initiates the shoulder abduction? The initial one. Which one initiates, then which one comes in the middle from 15 to 90 degrees, and what comes in the overhead abduction? Remember, when you are saying abduction, abduction is like taking the shoulder up, supra. So please remember that it is supraspinatus which initiates the abduction, right? And above 90 degrees, overhead abduction requires? Overhead abduction requires? The overhead abduction, remember, it is set. What is set here? The mnemonic is set. What is set? So you are set for overhead abduction. Remember like that. Set is serratus, S-E, serratus anterior and trapezius. Okay, it is serratus anterior and trapezius. Is this clear with everyone? Serratus anterior and trapezius. And remember, the paralysis of both these muscles, it can lead to winging of the scapula. Serratus anterior is medial winging of the scapula. Trapezius wala is lateral winging of the scapula. Right? Is this clear with everyone? Medial winging, lateral winging. Going to next one, bicipital groove. The floor is formed by, like, what muscle is inserting onto the floor of the bicipital groove? So what is the mnemonic for that bicipital groove? It is lady between two majors, right? So remember, there's a lady between two majors. So in the floor is the lady. Lady is basically standing for latissimus dorsi muscle. Okay, latissimus dorsi. Which one goes on the lateral lip and which one goes on the medial lip out of teres major and pectoralis major? Remember that pectoralis has L in it. It is the lateral lip. The teres major is on the medial lip. Very, very important. Okay, clear with everyone? Going to next one, scapular winging. Remember, there is medial winging and lateral winging. Medial winging is more common. So medial winging is basically what nerve injury? Injury to what nerve causes the medial winging of the scapula? It is the long thoracic nerve. Long thoracic nerve causes medial winging. Okay, and it is long thoracic nerve is what muscle? Remember, it is serratus anterior. Okay, it is serratus anterior muscle. Long thoracic nerve. Okay, so they just not every day. I'll give you an update on Telegram group when there are sessions, right, for the upcoming other subjects as well. Long thoracic nerve injury causes medial winging. We just now said that lateral winging will be caused by. So basically, if the question is what nerves are involved in winging of the scapula? Winging of the scapula is what nerves? Remember, the mnemonic is LSD. What is LSD? Long thoracic nerve, spinal accessory nerve, and the dorsal scapular nerve. Okay, and the dorsal scapular nerve. Is this clear with everyone? Yes. So what is the mnemonic for the winging? It is LSD. Out of that long thoracic nerve, serratus anterior is the medial winging. Okay, that is the medial winging. The other two are the lateral winging. The other two are the lateral winging. We have discussed in detail all of this in our short videos कि फिर dorsal scapular किसको supply करता है, long thoracic nerve root से आता है, उसका root value C567 है. All of this we have discussed in detail, right? We are just focusing on the most important points here. Going to next one, brachial plexus injury, right? Erb's palsy, tell me, is what trunk injury? Upper trunk, middle trunk or lower trunk? Erb's palsy, brachial plexus में हमने with all the mnemonics discuss किया है कि उसमें 5 roots आते हैं, upper limb में 5, C5 to T1 आता है. Okay, so tell me which trunk. Remember, write Erb's as Erb's. To remember, it is U, that is upper trunk injury. When you say upper trunk, C5, C6, पहले के दो वाले, that is what is injured here. Okay, C5, C6. So when there is Erb's palsy, it presents as what hand? Is it a claw hand or is it a tip hand? Policeman's tip hand or potter's tip hand? Yes. Remember, it is the tip hand. How do you remember this is? Remember, in the top trunk when it goes, upper trunk is the top trunk, so it gives a tip wala hand. Tip, top. Tip is seen in top trunk involvement. It could be policeman's tip, potter's tip hand. So where you will have what shoulder? Adducted shoulder. How is the arm? Medially rotated. How is the elbow? Extended. And how is the wrist? Basically, it is pronated. Okay, it is pronated wrist which is there. Okay, clear with everyone? Remember it as tip top. Tip hand is seen in top trunk involvement. While what hand do you see in clump case paralysis? Remember clump case KL. Remember it as claw hand. Okay, claw hand is seen in clump case. That is the lower trunk. Okay, that is the lower trunk involvement. Going to next one, the arm fractures and the nerves. Fracture of the surgical neck of the humerus, right? The neck of the humerus will damage what nerve? Remember, you have neck fracture and the shaft fracture. Neck fracture is the axillary nerve and the shaft fracture is the radial nerve, because in the spiral groove, right? In the spiral groove on the shaft, you have the radial nerve. And when there is axillary nerve injury, there is sensory loss classically over the regimental badge anesthesia. That is what it is called as, regimental badge anesthesia. There is loss of sensation here in the upper arm. Okay, so remember that is regimental badge anesthesia. Is this clear with everyone, guys? Okay, very, very important. All of these are PYQ, so they are highly important for your exam. Going to the gluteal nerve, superior gluteal nerve and inferior gluteal nerve, right? So remember that out of this, the gluteus maximus is supplied by what nerve? Inferior or superior gluteal nerve? Remember it with the mnemonic gluteus maximus. Maximus सिर्फ नाम बड़ा है, दर्शन छोटे हैं, छोटा मतलब inferior. It is the inferior gluteal nerve which supplies gluteus maximus, right? And maximus has what main action is maximus? Remember, max is ax. It is extension. Hip extension is what is the major action. It is not the hip abduction, which is the primary action of gluteus maximus. So very, very important topic that's frequently asked in your exam, the Trendelenburg's test, right? The Trendelenburg's, where you look for the drop of the pelvis, right? Remember, first of all, it is what nerve and what muscles. A positive Trendelenburg sign indicates weakness in what gluteus muscles? The primary abductor muscles. That is also the question asked. It is gluteus medius and gluteus minimus, right? And that's basically what nerve? It's not inferior, so it is superior gluteal nerve. So that is damaged on what leg side? The patient is standing on one leg and there is other side that you are looking at. So tell me that which side is affected? The side which is dropping or the side on which the patient is standing? Remember, it is the standing leg side that is supported wala. Remember, it is standing. AN side is abnormal. Drop is opposite side which drops. Okay, the opposite side which is drop. Is this clear with everyone? Standing wala abnormal hai. ठीक है? Standing, remember AN, standing is what is basically abnormal. AN, abnormal is standing. Drop is opposite side. Okay. Going to popliteal fossa, another topic that we have discussed in short. Popliteal fossa mein the structures from superficial to deep. What is the sequence? Is it vein, artery, nerve? From superficial to deep, you are looking from the posterior side, popliteal fossa. So close to the bone, सबसे क्या है deepest close to the bone? Is it nerve, vein, artery? Is it vein, artery, nerve? Or is it some other sequence? What is the sequence? Which is the deepest structure resting closest to the femur, and that is why it's very difficult to palpate it. What is difficult to palpate is the popliteal artery. Remember, is the deepest. Okay? And the sequence from superficial to deepest, NVA. First is the nerve. What nerve comes in the popliteal fossa? Not the boundary. It is the content in the popliteal fossa. Remember, is tibial nerve. Okay? You remember it as tibial nerve goes through, T for T. Tibial nerve goes through the popliteal fossa. Peroneal nerve, remember peroneal, P-E-R is in the periphery. It forms the lateral border of the popliteal fossa. Okay, so NVA is what is the sequence? Nerve, vein and artery. Artery is the deepest. That is why popliteal artery is difficult to palpate. Going to joints, we have discussed all the quick tricks for joints, how to remember which is saddle joint, which is ball and socket joint. So tell me that the first carpometacarpal joint is what kind of joint? The first CMC joint is what kind of joint, guys? Yes, very good, Harini. That's the lateral border for the peroneal nerve. The first CMC joint is what joint? Is it hinge, ellipsoid, saddle, ball and socket? What joint? Yes? Remember, it is a saddle joint. What is the mnemonic for the saddle joint? Remember, we have learned the trick is CMC. That is the first CMC. इसमें से M निकाल दो एक अल्फाबेट, फिर बचेगा CC. That is calcaneocuboid. C निकाल दो, S add कर दो, that is ST, sternoclavicular joint. Right? These are the tricks that we have already learned in our short videos. Okay, so that's a saddle joint. Which ossicle wala joint is a saddle joint? Malleus incus or incus stapes? Remember, malleus incus MI. Anybody getting MI is a sad event. So that is saddle, sad event. MI is sad. So it is saddle joint. Atlantoaxial joint, on the other hand, is what kind of joint? Remember, atlantoaxial joint is basically for yes movement or no movement. Remember, it has axis, has X in it. X matlab no movement, that is rotational movement. And wherever there is rotational movement, you think of the pivot joint. Okay, that is the pivot joint is for rotation. Okay. Next topic we have discussed dermatomes, very important. So thumb का dermatome बता दो क्या है? Thumb is what dermatome? Is it C5, C6, C7 or C8? Yes? Thumb, right? When you form thumb से SFL बनाओ, so this is like the number 6. So remember, this is the number 6. So thumb is C6, right? So take the alternate fingers here. Thumb is C6, middle finger is C7 and the little finger is C8. So it is C6, C7 and C8, thumb, middle finger and little finger. Okay. So this is done. The upper limb, lower limb wala part. Going to the cranial nerves, the brainstem, very important. No exam is complete without a question on this, right? Cranial nerves, very important. So first question on the skull foramen. The maxillary nerve exits through what foramen in the skull? The maxillary nerve exits through what foramen? What is the trick that we have learned? Imagine a girl wearing maxi and she is rotating for boomerang, right? Girl wearing maxi rotating. So remember, it is foramen rotundum. Foramen rotundum. Okay, very important. So I'm not discussing all the foramen. We have discussed that middle meningeal artery, middle is spine, that is spinosum, male is man, mandibular nerve, ovale, male, ovale, man. Okay? Now tell me which skull foramen is located in the petrous part of the temporal bone. So you have the petrous temporal bone, right? You have the occipital bone coming here. So in the petrous temporal bone, not at the junction of petrous and occipital, is what foramen? Is it the jugular foramen or the internal auditory meatus? So remember, within, that is in, is internal auditory meatus. Okay, in the petrous bone is the internal auditory meatus. At the junction of petrous and occipital junction, JU is the jugular foramen. We have seen the image also for that. Okay. Next topic we have discussed is superior orbital fissure. The question is, what nerve passes through superior orbital fissure, but it is outside the annulus of Zinn, the common tendinous ring, out of the cranial nerve 3, 4, 6. Right? 3, 4, 6 supply the extraocular muscle. So out of that, which one goes outside the central tendinous ring? It's in the fissure, but outside the annulus of Zinn. Remember, the mnemonic is LFT is left out. That is outside. LFT. So T for trochlear nerve, that is the fourth cranial nerve, is out. LNF stands for lacrimal and frontal nerve, which are the branches of the ophthalmic part of the trigeminal nerve, the 5-1. Okay? Which branch of the ophthalmic nerve goes in the central tendinous ring? Remember, N is N, that is nasociliary nerve. Okay, nasociliary branch goes in the central tendinous ring. Okay, is this clear with everyone? Right. Going to cranial nerve characteristics. Which is the thinnest cranial nerve and the only cranial nerve with a dorsal brainstem origin? Dorsal, D for fourth alphabet. Remember, it is the fourth cranial nerve. The trochlear nerve is the only one which comes from the dorsal brainstem, and it is the most thinnest. The thickest is the trigeminal. Which nerve has the longest intracranial course? It's the fourth which has the longest intracranial course. But when you are talking about ki raised ICT में जो affect होता है, then the answer will be the sixth cranial nerve. Otherwise, the longest intracranial overall is fourth. But the longest, like in the subarachnoid space, that is going to be the sixth cranial nerve. So that is affected in raised ICT. When the sixth nerve is affected, tell me that the patient will have what squint? Medial squint or lateral squint? What squint will the patient have when the sixth nerve is affected? Yes? So sixth, remember, it is LR6. Lateral rectus is supplied by 6. So when lateral rectus is gone, the patient will have medial squint, not the lateral squint. The lateral is paralyzed. It is medial. So remember, it is the sixth nerve which gives this false localizing sign in raised ICT. Okay? Which are the medial cranial nerves? The cranial nerves arising from the medial aspect of the brainstem. What is the trick that we have learned? The medial cranial nerves follow what rule? Rule of 4, rule of 6, 8, 12. What rule is it? What is the rule for the medial cranial nerves? It is the rule of 12. So basically the numbers which have 12 in their table. So which are the medial ones? You have starting from the cranial nerve 3, not 1 and 2. Very good. It is 3, 4, 6, 12. Okay, very good. It is 3, 4, 6, 12 which are medial. Remember, medial, M for M. So they are purely motor nerves. 3, 4, 6 extraocular muscles. 12 is the tongue muscles. So they are pure motor nerves. Right? So this will not be involved in sensation. Like for example, previous INICET exam question, 12th nerve has no role in olfaction. It's a pure motor nerve. Okay. Going to the next one, tongue wala topic that we have discussed. So which nerve carries the taste sensation from the anterior two-thirds of the tongue? Remember, for the taste, where is the taste, the gustatory pathway going to what nucleus? It is nucleus tractus solitarius. NTS is what nerve? N for 9, T for 10, S for 7. So it is 7, 9, 10. And that is how you have the taste from the tongue also. It is 7, 9, 10. So the taste is carried by the 7th nerve. Konsa branch of the 7th facial nerve? It is chorda tympani nerve. Okay, it is chorda tympani. And what nerve carries the general sensation from the anterior two-thirds? It is the lingual nerve, which is a branch of fifth cranial nerve. The trigeminal lingual carries the general sensation. Very, very important. Frequently asked. Very, very important. And in the posterior one third, remember after 7 comes the 9. It is the glossopharyngeal nerve, which has both the general sensation and taste from the posterior one third. Also remember that all tongue muscles are supplied by the 12th, the hypoglossal nerve, except which muscle? Which is not supplied by the hypoglossal? Yes? The palate says that it is my muscle, not the tongue muscle. So remember, palate says it is palatoglossus, which is not supplied by the hypoglossal, right? Going to next one in salivary glands. What nerve carries the parasympathetic secretomotor supply to the parotid gland? Yes? So कौन से न्यूक्लियस से कौन से गैंग्लियन में जाता है, फिर जाता है वो पैरोटिड ग्लैंड में. So what is the nucleus? What is this preganglionic nerve? What is the ganglion? And then going to the parotid. Yes? So first of all, tell me, parotid is what ganglion? Otid is otic. Remember rhyming. Otid is otic ganglion. Parotid, remember P ka ulta is 9. So the preganglionic one is the 9th nerve. Remember P ka ulta 9. Glossopharyngeal 9. It is what salivatory nucleus, superior or inferior to the parotid? Remember when I say 9, it is IN. It is the inferior salivatory nucleus. The superior salivatory is the 7th. SSS. Superior salivatory 7 going to the submandibular and the sublingual gland. Okay? Is it clear with everyone? Inferior in is 9. It is parotid otic. Okay, that is what you should remember. Very good. Coming to next one, brainstem syndromes. There's an entire video on this YouTube channel as well. So you can watch that. Very, very, a good video with all the tricks for brainstem syndromes. So remember facial colliculus, favorite for the exam. Facial colliculus is basically by nucleus. Which nucleus and which fibers? Do not confuse here. It is the nucleus of the 6th nerve, the abducent, and wrapping around it is the 7th nerve, the facial nerve fibers. Okay, so 6th nerve का nucleus है और 7 के fibers है. Medial medullary syndrome is what is called as Dejeron syndrome, right? The medial medullary syndrome is the Dejeron syndrome. And which medullary syndrome involves the tongue? The medial medullary or the lateral medullary syndrome? Remember, tongue is 12th. 12th, 3, 4, 6, 12 is medial. So 12 is a medial cranial nerve. So in the medial medullary syndrome, you will have the tongue deviation present, not in the lateral medullary syndrome. So when I say there is tongue deviation present, it is to what side? So medial medullary, remember it damages the cranial nerve 12 because it is arising from the medial medulla. 9, 10, 11 is from lateral medulla. So tongue deviates to what side? Remember it is same side. What is the mnemonic? Tongue licks the wound. Whichever side there's a lesion, the tongue will lick it. It will go to that side. It is deviated to the same side. Very, very important. Lateral medullary syndrome is what syndrome? Is it Weber, Benedict, Wallenberg? What syndrome is lateral medullary syndrome? Remember, LA, lateral medullary syndrome is Wallenberg syndrome. Okay, ALLA, Wallenberg syndrome. It spares the medially located what nerve? 12th nerve is not involved in the Wallenberg. Okay, remember 12th nerve is not involved in Wallenberg. Very, very important. Out of Dejeron and Wallenberg, tell me which one has Horner's present? Horner's will be present in lateral or medial medullary syndrome. Yes? Very good. Remember, Horner's is basically involvement of the sympathetic trunk. Sympathetic trunk. S for S. Sympathetic trunk, remember S for S is present on the side, that is the lateral side. So lateral medullary syndrome will have Horner's, not the medial one. Okay, clear with everyone? Give me a quick thumbs up if this is clear with everyone. We'll go to the next one, which is again neuroanatomy wala part. This was dedicated to the brainstem and the cranial nerves. Now going to the rest part, which is important in the brain, the cortex, the areas. So important topic we have discussed in short, Brodmann areas and aphasia. So Broca's area basically is what area? What Brodmann area is Broca's? And Wernicke's. Remember the mnemonic for Broca's. Remember Broca's area when gone, the patient has broken speech. That means the fluency is gone. Remember the alphabet coming proximal, BIF. Right? It is inferior frontal. जो पहले वाले हैं. So Broca's is located in inferior frontal gyrus. FFF. Also remember it is what number for Broca's? 44, 45. FFF. It is area 44, area 45. Very good. So that causes a loss of speech, fluency, broken speech in Broca's. And Wernicke's. Remember the mnemonic for Wernicke's is West. What is West? Wernicke's ST. It is superior temporal gyrus. Remember temporal is TT. Right? Area number TT 22. Okay, 22 is Wernicke's. Remember how is the speech in Wernicke's is wordy. Broca's is broken. Wernicke's is wordy speech. Patient speaks a lot, right? And there is word salad which is formed. The fluency is not affected. There is receptive aphasia. Basically the comprehension which is gone. Okay, comprehension affected along with repetition. Which is that aphasia where the only repetition is gone? It is conduction aphasia. Right? Only repetition gone is conduction aphasia. When I say conduction aphasia, where is the lesion? When I say conduction aphasia, where is the lesion? Remember, you have Broca's, you have Wernicke's. Connecting the Wernicke's and the Broca's is this fasciculus, which is the arcuate fasciculus. So, conducting is arcuate. So, remember, conduction is arcuate fasciculus. Lesion is what leads to conduction aphasia. Only repetition is gone. Fluency and comprehension is maintained. Very good. Going to the next one. Area 41 and 42, which is the Heschel's gyrus. What is Heschel's gyrus related to? What sensation? Is it the vision? Is it auditory? Is it speech? What is Heschel's related to? It's a PYQ. Remember it as Heschel's, H-E-H-E. Heschel's is for hearing. So that is primary auditory cortex, area 41, 42. Remember the story? First you listen, 41, 42. Right? Then you taste, 43. And then you speak. I've told you the story in the short video. So that is speaking is 44, 45. Okay? And which is the primary visual cortex? Visual is you see with the visual cortex. C is S-E-S-E, area 17. 17, seeing ke liye, 17. Going to the cerebral vasculature. What is a branch of the ICA, but it is not a part of the circle of Willis? Terminal branch hai. ICA में से आता है ACA or MCA, right? And this is where the circle is present. So you can see that MCA goes out of the circle. So remember, MCA is not a part of circle of Willis. Which cranial nerve passes between the PCA and the SCA? PCA and SCA come from which artery? So you have basilar artery. Terminal branch is PCA, second branch is SCA, and the nerve going in between these two arteries. It is what nerve? It is the third cranial nerve. Okay, very important. It is cranial nerve third which passes between these two arteries. Okay? So, cranial nerve third, basically if there is an aneurysm, what aneurysm is common? PCOM aneurysm compresses the third nerve, right? If there's a PCOM aneurysm compressing the third nerve, so will the pupil be involved or pupil be spared? Remember, in the third nerve, the pupillary fibers, they are peripheral. Remember, PPP, pupillary peripheral parasympathetic fibers in the third nerve. Okay, PPP. So when there is compression from outside, the pupil will be affected because it is in the periphery, right? So what pupil do you get in the third nerve palsy because of aneurysm? Constricted or dilated pupil? Remember, third nerve palsy is a dilated pupil. Okay, it is dilated pupil. Where do you have pupil sparing third nerve palsy? Pupil sparing third nerve palsy is diabetes mellitus, where the blood supply is affected, right? In the center, periphery is spared. So pupillary sparing is there. Is this clear with everyone? Thank you so much, Riddhi. I'm happy to read your comment. Really makes my day. All right, going to the next one, thorax and diaphragm. The diaphragmatic openings is what we have discussed in the short videos. So what is the mnemonic for diaphragmatic openings? Remember, I, 8, 10, X at 12. I is 8, IVC is T8, 10 is esophagus. Aorta, thoracic duct is 12. Okay, AAT, at aorta, azygous vein, and thoracic duct is T12. So vena cava, IVC is at T8. It transmits the IVC, and what nerve goes along with the IVC? What phrenic nerve? The right or the left? Remember, it is the right phrenic nerve. So remember, IVC drains into the right atrium. Veins are present on the right side. So along with that goes the right phrenic nerve, not the left phrenic nerve. Okay? And remember, this caval opening, CC, caval opening is what is present in the central tendon of the diaphragm. Esophagus 10X is at T10. Along with esophagus goes what nerve? Remember, esophagus ka rhyming is vagus. So esophagus and vagus go together. Aortic hiatus at 12. At 12. Remember, AAT. Aorta, azygous vein, and a thoracic duct. Okay, thoracic duct, azygous vein. This is present at T12. Okay, that is T12. Going to next one. So hernia may, what is the most common congenital diaphragmatic hernia? Is it Morgagni hernia or the Bogdelic hernia? Remember, it is Bogdelic hernia, which is the most common congenital diaphragmatic hernia. What is the most common position? Remember, when I say Bogdelic, you should have this visual memory. Okay, left posterolateral. It is left posterolateral. It is due to failure of fusion of what structure? Is it septum transversum or the pleuropericardial membrane or the pleuroperitoneal membrane? Yes? Septum transversum, pleuropericardial or pleuroperitoneal? Remember, when we talk about the diaphragm separating the thorax from the abdomen. So you have the pleura here and the peritoneum here. So it is pleuroperitoneal membrane and not the pleuropericardial membrane. Okay? So left posterolateral, this is going to be pleuroperitoneal membrane, not pleuropericardial. Going to next one, sternal angle is basically what vertebral level? Sternal angle. Remember, this is T4 level. Okay, T4. So this is the nipple dermatome as well. Remember, the dermatome for the nipple. Nipple is like a pore in the breast. Pore rhyming with 4. So remember, nipple is T4. Okay, the dermatome for nipple is T4. At T4, you have bifurcation of trachea, not the carotid. Remember, bifurcations at C4, T4, L4. So 4, 4, 4. C for C, carotid bifurcation. T for T, trachea bifurcation. L for aorta bifurcation. So remember, bifurcation is bifurcation. The bifurcation occur at 4, 4, 4 level. At T4, it is tracheal bifurcation, and also the level where the aortic arch starts and ends. Okay, ascending aorta, फिर बनता है arch, फिर descending. So this is going to be the T4 level where the arch is starting and ending. Okay, clear with everyone? A quick thumbs up if this is clear with everyone. We'll go on to the next segment, which is embryology ke important points. Yes? So very, very important topics that we have discussed in our short videos: pharyngeal arches, pharyngeal pouches, aortic arches, neural crest cell and the reproductive system, mesonephric duct, paramesonephric duct, right? So we'll see quick questions for assessment and active recall here. So tell me, muscles of mastication originate from what arch? First. Remember, first arch is the arch of M. Stapedius, S. Remember S for S. It is the second arch. S for S, second arch, seventh nerve comes the facial nerve. Okay, stapedius is supplied by facial. Very, very important, third arch ka only muscle is stylopharyngeus, not styloglossus or stylohyoid. It is stylopharyngeus, which is coming from the third arch, and the third arch is what nerve? 9 cranial nerve. Remember 3 ka square 9, and 9 when you write uska ulta is P. So it is stylopharyngeus, not stylohyoid or styloglossus. Okay, where else did we see 9 and P? Parotid glossopharyngeal nerve, preganglionic wala. Okay. And which is the muscle, the laryngeal muscle from the fourth arch? The rest of the laryngeal muscles is sixth arch. Which laryngeal muscle is the fourth arch? So the only muscle not supplied by recurrent laryngeal nerve, it is supplied by superior laryngeal nerve ka branch, which is external laryngeal nerve. Remember, it is cricothyroid. Cricothyroid. Is this clear with everyone? Cricothyroid is the fourth arch ka muscle. Going to next one, pharyngeal pouch. What pouch develops into thymus and inferior parathyroid? First, second, third, fourth. Remember, it has third pouch. TH and I. TH for thymus, not thyroid, and I for inferior parathyroid. Okay. Thymus and inferior parathyroid is the third pouch. So, defect of which will lead to what syndrome? Thymus gone. There will be immunodeficiency. Thymus important for T cell immunity. And parathyroid gone. What will the patient have? Parathyroid gone, calcium gone. The patient will have hypocalcemia. So what syndrome is this? It is Di-George syndrome. Catch 22. Chromosome 22 is involved. Right? Remember, very, very important. Immunodeficiency with hypocalcemia. Going to aortic arches. The left recurrent laryngeal nerve loops around what structure? Which is the longer recurrent laryngeal nerve? The left recurrent laryngeal nerve. It loops around the ductus arteriosus, which develops from what aortic arch? Ductus arteriosus. Remember ductus, D. D ko agar aap ulta karoge, so it is going to be sixth. And what sixth arch? The left or the right? Very specifically, remember, it is the left sixth aortic arch, right? Connecting the aorta and the pulmonary on the left side. So that is left sixth aortic arch. Very, very important and frequently asked. On the other hand, remember the arch of aorta comes from what aortic arch? ARCH is how many letters? 4. So remember, it comes from the fourth aortic arch. Which one? The left or the right? Remember, arteries on the left, veins on the right. The aorta is coming from the left ventricle, right? So remember, it is the left fourth arch. It is the left fourth arch, not the right fourth arch. Okay? Going to neural crest cell derivative. What is the mnemonic we have seen in Sure Shot? MPSC goal is like a crest. So there, tell me that adrenal cortex or adrenal medulla. What comes from the neural crest cell? Adrenal cortex or medulla. That this has been asked in the recent INICET exam also. Yes. Very good. What is the mnemonic for this? The adrenal cortex and medulla. C is for M. M is for C. The adrenal cortex is derived from mesoderm. C is for M. The adrenal medulla is derived from crest cells. So remember, it is adrenal medulla. Okay. Remember medulla, M-E-M-E, melanocytes. MPSC goal mein M for melanocytes. So medulla, melanocytes, they come from the neural crest cell. Okay, clear with everyone? Going to next one, the appendix of testis is the remnant from what duct in adult males? Remember, in the males, which is the main duct which is leading to the development of the reproductive tract? Males are wolf, right? Not literally, but just for the mnemonic. So remember, it is Wolffian duct which is important in males. ठीक है, Wolffian duct is important in males. So it is the Wolffian duct is the mesonephric duct. The paramesonephric duct is in females, right? The Mullerian duct, paramesonephric duct. So the appendix of testis, not a very important structure. So that is not from the mesonephric, that is from the paramesonephric duct. Okay, paramesonephric duct. Is this clear with everyone? From the mesonephric duct in males, what is the mnemonic for the structures developing? Remember, it is seed, seminal vesicles, epididymis, ejaculatory duct, and ductus deferens, that is vas deferens. They come from the mesonephric duct. Appendix of testis is going to be from the paramesonephric duct. Okay? All right. Coming to the last segment, that is the reflexes. Knee jerk, triceps, and cremastric reflex. Okay, tell me the root values here. Our very favorite mnemonic there, the rhyme there. 1, 2, buckle my shoe. 3, 4, clean the floor. So 1, 2, buckle my shoe. You are buckling the shoe where? At the ankle. So ankle is 1, 2. Shoe is S. So S1, S2. 1, 2 is going to be S1, S2 is ankle reflex. Okay. Then you have 3, 4, clean the floor. The pocha marte on the knees, cleaning the floor. So that is 3, 4, that is L3, L4. Okay, what are you looking for? The knee extension. Then you have 5, 6, pick up the sticks. So you're picking up the sticks with the biceps flexion. And 7, 8, triceps, piche, extension wala. That is shut the gate like this. So remember, triceps is C7, 8. Right? 5, 6 is biceps, 7, 8 is triceps. So 1, 2 ankle, 3, 4 knee, 5, 6 biceps, 7, 8 is going to be triceps. Cremasteric reflex. It is evaluating what spinal roots, guys? Cremasteric reflex. Yes? Cremasteric reflex, when we are stroking on the thigh, imagine along the groin. Remember, groin, O-I-N is O-N-E, L1, 2 area. So remember, it is L1, L2 spinal roots. The efferent, not the afferent, is what nerve is the efferent for the cremasteric? So stroking on the thigh, you are looking for the testis getting elevated. Testis, the gonads, the genital. Right, so you're looking for the genital wala, that is the efferent is going to be the genital branch of the genitofemoral nerve. It is the genital branch of the genitofemoral nerve. Is this clear with everyone? Right, the afferent is the ilioinguinal nerve, right? Ilioinguinal in the groin, L1, L2, and then the efferent is the genital branch of the genitofemoral nerve, causing the elevation of the genitals. Okay? Right? So these were the most important, right? A quick sneak peek into the various mnemonics that we have learned in our short course, short videos on MedSynapse app. I have tried to at least get the crux, the most important mnemonics here, where generally we tend to make mistakes, the ones which are frequently asked in the exam, right? And like I told in the beginning of the session, what you have to do is immediately after the session, revise this, then give 1 day ka gap, and day after tomorrow, give the test, the short anatomy short based test, which is available in MedSynapse app based on whatever you have learned here, and see whether you are getting 100% accurate or not. If you are not getting 100% accuracy, mark in this notes where did you make a mistake, highlight that and keep revising it. Okay, that test is available only to the MedSynapse app subscribers in the short course. Okay. So that was about the today's session, guys, the anatomy short sprint, where we had the most important mnemonics, the most important topics from anatomy short, which was squeezed out and discussed today. I hope all of you have enjoyed this session. That's great. Yes, Harini, Neha, I'll try to do it for the other subjects as well. Right? What I need from all of you is just creating awareness about these sessions. Share it with your friends, right? So that it helps us to reach to more students as well. We help many more students, right? So I'll see you again soon. I'll update you on the Telegram group for the next upcoming session. The next session that we have is on the MedSynapse app live session as well, which will be coming up, right, which is day after tomorrow, 7th, where you will have Microbiologica KBMD with the live leaderboard, the live poll, right, like you have Kaun Banega MD session in app for subscribers day after tomorrow on 7th. Okay. Thank you so much, everyone. I'll share the annotated PDF as well on the Telegram group. So you can get the annotated PDF as well. Blank PDF I've already shared. Right. So thank you so much. Goodbye. Take care. And keep studying, keep revising, keep med synapsing, and keep winning.